Dyspnea absent except in infants. Mind you, in a very young baby, in an infant, a unilateral vocal cord palsy can produce stridor and breathing difficulty because of the redundant tissue and because of the narrow glottic aperture and because of the Bernoulli effect. There can be stridor, but otherwise unilateral vocal cord palsy won't produce dyspnea. But there is a condition known as phonatory dyspnea. Sometimes patient will tell that I am feeling dysnic. But when you on close interrogation, you will find that this is actually phonatory dyspnea. When patient is talking, normal people can easily talk 25 to 30 words in a single breath. These people will be able to take only 3-4 words. So they are short of breath. They feel that they are short of breath. This is known as the phonatory dyspnea, not a true dyspnea. And maybe obvious causes may be present, like a history of a thyroid surgery or something like that, or absent. If absent, we all know that we have to investigate with a CT scan from skull base to sternal angle, the whole neck, to rule out the space occupying lesion, something in the recurrent laryngeal nerve course. Now, diagnosis is by laryngoscopy. You can use flexible and rigid, but it is preferably is flexible because that is you are examining the vocal cord in a physiological position. Rigid, you are holding the tongue. So the general rule will be for structural lesion you use a rigid scope, and for the functional lesion like the neurolaryngology, the muscle tension dysphonia, all use the flexible. Better still if you have a chip on tip rather than the conventional flexible. Chip on tip is almost as good as the rigid in clarity, and it has got all the advantage of a flexible laryngoscopy. Stroboscopy, minimal additional value only in vocal cord palsy because we are not generally dealing with a Rangi space. So unless there is something in the Rangi space, stroboscopy is not going to add much to the diagnosis. It will just say that the mucosal waves are more on the affected side. Mind you, mucosal waves are more on the affected side, not on the normal side. Many youngsters would misconcept that, in vocal cord palsy, mucosal will be absent. Mucosal will be present more. So now we start our diagnostics endoscopy. When you do the flexible laryngoscopy, you have to look into these many factors. You have to look into the abduction, you have to look into the adduction, you have to look into the phonatory gap, you have to look at the symmetry. This is a very important concept. When we were all students, we were all taught, even 10, 15 years back when I started 20 years back when I started laryngology, most of the teachers were telling that look at the anterior commissure till you see the anterior commissure, laryngoscopy is not complete. So with the result then, what happened? We were always looking at the anterior commissure. We completely forgot one of the vital parts of the larynx, that is the arytenoid. The posterior glottis will tell you a lot of things. And unfortunately, even now in textbooks, they are not taught really. So you have to pay a lot of attention how the arytenoids behave. It will tell you a lot of things. We will see a little later. Look for vocal cord atrophy. Look for vocal cord flaccidity. Look at the ventricle and look at for any supraglottic phenomena. So this many things you have to look, not just the adduction. In unilateral vocal cord palsy, you might be looking just at the adduction. No, you have to look at the abduction, the phonatory gap, the symmetry, the vocal cord atrophy, the vocal cord flaccidity, the ventricle, supraglottic phenomena. Of course, if stroboscopy is there, you look for the mucosal. Now, abduction. If the clue here is that, sometimes you may not actually see the vocal cord properly in abduction. You will just concentrate on adduction. What is the importance of abduction? If the abduction is normal, the entire length of the vocal cord is visible. That's an important point. If you are not seeing posterior 1/3 of one vocal cord, chances are that you are dealing with a partial abductor paralysis. So look here, you can see both. Look at the arytenoid where the normal side you can actually entirely see the. Now watch, this is a left vocal cord palsy, and when the patient is taking breath, you can see that the entire cartilaginous cord and membranous cord is visible on the right side. But on the left side, you see that you can see only the anterior membranous cord. The posterior cartilaginous cord is not seen. So this helps you, not in this case, sometimes diagnosing some difficult cases. So always look, or when patient is abducting, look whether you can actually see the cartilaginous cord. You should be able to see the cartilaginous cord completely, because that's a normal way. When patient is abducting, the vocal cords are abducting, the entire length of the vocal cord should be visible. Now, this is very useful to differentiate a BVCP or a UVCP from a CA joint ankylosis. This doctor, he's actually a doctor and he was a very good singer too. He had an intubation for some respiratory infection much years back when he was an adolescent, and his vocal cord, cricoarytenoid joint, got fixed. But look at the posterior glottis. See, you can see even on the immobile cord, you can see the entire glottis, entire vocal cord. So this is not a vocal cord paralysis. Actually, it was a cricoarytenoid joint ankylosis. So this sometimes, many times, it gives clue. So in an abductor paralysis, you won't be able to see the posterior cartilaginous cord. So always learn to look, train your eyes to look at the posterior cord as well as the arytenoids. Now look for the adduction. With stroboscopy, you will get a perfect closure. But without stroboscopy, a small parallel phonatory gap is normal, because only when the mucosal wave there, you get a real complete closure. So I will show both. But a parallel, symmetrical, here you are not able to see the mucosal wave because it is not a stroboscopy. So a small parallel phonatory gap, it's actually an illusion, because there is when the mucosal waves are happening, the closure will be complete. Now we look what all things happen. We know that the vocal cord has got three adductors. The anterior 1/3 or the anterior half is adducted by the thyroarytenoid. The vocal process is adducted to meet each other by the lateral cricoarytenoid. And the posterior glottis, that is the part of the cord glottis, corresponds to the cartilaginous vocal cord, that is behind the vocal process, is actually brought together by the interarytenoid. So you can have different combinations. You can have isolated thyroarytenoid paralysis. You can have isolated lateral cricoarytenoid paralysis. You can have isolated interarytenoid paralysis, or you can have combinations of various combinations. So your aim is to identify each vocal cord palsy and understand what type of palsy it is, because that is so much important. Then only you can plan the correct treatment, because the treatment varies from one condition to other. This is which has happened over the last 20 years. 20 years back, when we watched a thyroplasty being done by a master, we got excited. We go back home and do a thyroplasty, and the result is not good. The reason was that maybe the technique was there, but the main reason was that the selection of the patient was not really correct, because not every unilateral vocal cord palsy is similar. Each one is different. So you have to identify what exactly this patient requires and what exactly the other patient requires. For that, you have to have real keen observation, and you have to train your brain and eyes to pick up the findings. Now look here. If you look carefully, you will see the vocal process are meeting. You can see that the vocal process are meeting, but the left vocal cord is not come. And mind you, this is a stroboscopy. There is a phonatory gap anterior part. So this is actually an isolated thyroarytenoid paralysis. Lateral cricoarytenoid is fairly good enough. It actually keep the vocal cord in adducted position. There is some weakness, all right, because this was a post-thyroidectomy, neuropraxia, or whatever it is, or neurotomesis. But the important part which was affected was the thyroarytenoid. The patient doesn't have much problem at the mid-glottic level, that is at the vocal process, and posterior glottic level. Nothing, no problem again. You can see that again, once again. Even the abduction was not very great. Again, watch the abduction. You can see the right vocal cord, you can see completely. The left vocal cord, posterior glottis is not very seen, but you can see the vocal process are practically meeting very well. So what this patient requires is only medialized. Of course, this patient might have recovered, I don't remember, because this was a neuropraxia. But this is the ideal case. If at all you are going to start a thyroplasty for the beginner, this is the ideal case. Because there is good tone in the lateral cricoarytenoid, vocal cord bulk is there, there is a good no flaccidity, only an anterior phonatory gap. They will improve tremendously with a thyroplasty. So if a junior picks up this kind of case and do the thyroplasty, he or she will gain a lot of confidence because the result goes up naturally. Now there are some patients where there is a maybe associated with an anterior phonatory gap or just alone. A middle phonatory gap, or where the lateral cricoarytenoid is not working properly. Watch this case. You can see that the vocal process are not meeting. The gap is far more posterior. You can see that the V. Patient is struggling, but the vocal cord, so it is a more of a V-shaped phonatory gap. Patient is attempting to close, but at the vocal process level, they are not meeting at all. And there is some amount of bowing of the right vocal cord, the left vocal cord. So this is a thyroarytenoid plus lateral cricoarytenoid paralysis. Here, if you do thyroplasty alone, the results will not be very great because thyroplasty cannot correct a closure at the vocal process level. Whatever the some of the Westerners will say that, because there are people in Europe who will say that they will put a longer flange order. I don't think that really is physiological only, because you cannot adduct arytenoid. You can only rotate the arytenoid. So whatever flange you use, 8 millimeter long flange, nothing. It's not going to work. So you'll have to actually rotate the arytenoid here. So this is the case where you require arytenoid rotation. So when you're a beginner, don't pick this kind of case in the beginning, because you won't get a very good result with the thyroplasty. It will improve, all right, but the result will not be perfect. So here, this is the patient which require arytenoid rotation. Now, very rarely, less than say 1.5% of patients, you get isolated interarytenoid or combined interarytenoid paralysis. They are very, very difficult case. Here you can see that the vocal cords are moving. Even the vocal process is medializing. But look at the arytenoid. That arytenoid is far away. It is not coming posteriorly. So there is a gap behind the vocal process. We don't know why this happened. Because as far as we know that the interarytenoid has bilateral innervation. But there must be some anatomical variation where one side may be dominant, and that may be the reason. Watch here. You can see the abduction is normal. You can see the left vocal cord abduction is normal. You can see the entire vocal cord. You can see the anterior glottis is medializing. You can even see the vocal process beautifully moving. You can see that this vocal process is being tilted and built and brought more medial, but the arytenoid, posterior arytenoid, the cartilaginous phonatory gap is very big. It's not closing. This is a very, very difficult case. This is actually my case. Years back, when I didn't know about this condition at all, I actually went for thyroplasty and arytenoid rotation rather foolishly, because right now, retrospectively, I can see that this actually, the arytenoid rotation is not required. You can see the vocal process is medializing very well. But I didn't know any other surgery at that time. So I did the thyroplasty plus arytenoid rotation. Voice was not very good at all. I didn't understand. I didn't know how to correct. Then, this is some 10-15 years back. Now we know that there is a subgroup where the arytenoid is slipped off the facet and goes little more lateral. So for this, there is a specific surgery called adduction arytenoidopexy, almost similar to arytenoid rotation. You open up the expose the muscular process, open up the cricoarytenoid joint, and take a suture, figure of 8 suture through the cricoid and arytenoid, and fix it more medially. There are some American surgeons who say that you don't require arytenoid in any case. You can actually do adduction arytenoidopexy. Maybe, because when you put the arytenoid here, generally this also comes straighter. But I think there are different subgroups. So I will now do adduction arytenoidopexy only if when the arytenoid is far too lateral. Otherwise, I will do the arytenoid rotation, and a gap here I will do the thyroplasty. So you can combine all the three, depending upon, not all the three, 2 of the 3, depending upon what exactly is the pathology. Now, this is a very important concept. Look for symmetry. Look for the overriding arytenoid. If you look into the if it is the literature, they say that varying number, 15%, 20%, 30%, something like that. No uniform. So we have conducted a study. We have taken 197 normal patients, and they did an assay, and we have seen that 2/3 of the patient, more than 65% of the patient have got perfectly symmetrical arytenoids. But the rest 1/3, they don't have symmetrical arytenoid, but they are normal. They are normophonic. They don't have any voice problem. But either the right is overriding or the left is overriding. And of the overriding, that is around 33% or 1/3 of patient, 90% happens on the right side. I don't know. Maybe this is related to the dominant hemisphere, something like that. And 10% only happen on the left side. So this will be the finding. So mind you, these are not paralysis. They are just normal people. See, that is perfectly symmetrical. You can see that. If you look very carefully, you can see that the vocal cords are meeting in the midline, and the interarytenoid axis is parallel to the glottic axis. There is no change. This happens in 2/3 of patients. But some patients have got overriding. And at 90% it happened on the right side. You can see that. Now see that. Here it is an overriding, a right is overriding. And how do you know the arytenoid is overriding? It's very simple. Ideally, it should be corniculate to corniculate and cuneiform to cuneiform. So if some arytenoid, one side arytenoid is overriding, that side cuneiform will come in front. You can see that the right cuneiform is far in front when compared to the left cuneiform. And also see the interarytenoid axis tilts. It is no more parallel to the glottic axis. So this happened. This is a normal thing, sometimes called innocent or benign overriding of arytenoid. We have recently published a paper in pathology along with one of my fellow, Dr. Amrita. So you can you can see this finding. The interarytenoid axis is tilted, the glottic axis is different, but the patient doesn't have any problem. And mind you, 1/3 of patients have overriding arytenoid. They don't have any problem. We don't know whether it is the aftermath of a previous paralysis or it is just like that. I think it is quite normal to have one side dominant, like our right hand. We don't know. Now, 10% of people have left overriding arytenoid. Here you can see that left arytenoid is overriding. Again, you can easily understand left cuneiform is more in front than the right cuneiform. You can see very clearly here. See that this is more in front and the interarytenoid axis tilt this way. Again, not parallel to the glottic axis. Since it was very small, I thought it may be related to the dominance of the hemisphere. So we checked whether these people have the overriding arytenoid on the left. Are they left-handed people? Unfortunately, I couldn't find out any collaboration. So right now, I don't know why it happens, but it definitely happens. Now, with that background, we'll go back to your vocal cord palsy. In unilateral vocal cord palsy, now everybody can diagnose. That is not an issue. But vocal cord paresis can be very tricky. Sometimes you will not be very sure which is right or left because of the arytenoid movement. There are a lot of signs described, but I think the most important diagnosing sign is that the overriding arytenoid will be normal size. That is sensible enough, because if one vocal cord is paralyzed and both vocal cord meet in the midline, then normal has to override. So in vocal cord paralysis and vocal cord paresis, it is invariably the normal side which override. You can see now. You can see that this is a left vocal cord paralysis, and you see that the right is overriding. Again, watch the cuneiform relation and the angle. The arytenoid is tilted. So epiglottis, cuneiform corniculate make an angle. So this override and the cuneiform become in front. While on the non-overriding side, epiglottis, cuneiform corniculate is a straight line. But if the arytenoid is overriding, this will be an angle. Epiglottis, cuneiform corniculate. So it invariably happen on the right side. It never happen on the paralyzed side. But sometimes this overriding may not happen. Maybe patient is not trying too much, or maybe because sometimes a prolapsing arytenoid, paralyzed arytenoid may prolapse anteriorly. And this can also happen in a dislocation. So in a paralyzed vocal cord, if posterior cricoarytenoid tone is gone, the arytenoid follow anteriorly. So here the right vocal cord is paralyzed, but left cannot override. See that, you can see that because the right arytenoid is paralyzed and it is prolapsing, no way the left is still trying to override, but because of the mechanical obstruction, it really cannot override too much. So some surgeons have suggested that in this kind of patient, instead of in addition to doing thyroplasty, we should also knock off the arytenoid on the paralyzed side, submucosal arytenoid excision. I don't do that. I got different idea. We will discuss that little later. Now, suppose patient has got a vocal cord atrophy. What does that suggest? It suggests that the thyroarytenoid is involved. That is all. Because thyroarytenoid is the only muscle which is within the vocal cord, and which is the only muscle within the real lumen of the larynx. All other muscles are just outside or completely outside. So you can see that if one vocal cord is atrophic, then you should understand that this patient's thyroarytenoid is not working at all. So here you can see that when compared to the right, you can see that the left, the atrophied, you can see it very clearly. The bigger ventricle, you can see that the huge ventricle, some bowing and all these things. But you see that good mucosal wave. That is important. When the vocal cord is paralyzed, mucosal wave will be actually more. Suppose the vocal cord is too flaccid, what will happen? Then it suggests that the thyroarytenoid involvement is totally severe. It's actually complete or severe, because there is no tone at all. It will become so flabby. Of course, you should keep in mind superior laryngeal nerve palsy, but we will discuss how we can differentiate a flaccid recurrent laryngeal nerve paralysis from a superior laryngeal paralysis. So this is a classical flabby vocal cord from a complete paralysis of the thyroarytenoid. Again, one of my earlier cases, if you look carefully, you will see that the vocal processes are meeting perfectly. So that means the lateral cricoarytenoid tone is not bad. There is an anterior phonatory gap, but still it doesn't have any tone at all. When patient is trying to breathe, during phonation, actually vocal cord is pushed laterally because of the subglottic pressure. So there is no real tone at all. So it is a totally flaccid thing. Again, because of my inexperience, what I looked, patient had a very poor MPD and very breathy voice, very big phonatory gap. I thought I should do thyroplasty plus arytenoid. This again was 15 years back. I did a thyroplasty with an arytenoid rotation. The voice, the gap was completely closed, but the patient's voice was not very great. It improved all right, but I was not very happy. I didn't understand again at that time, but I could see that when patient was trying to phonate, even though adduction was there, when the subglottic pressure was building up, the vocal cord actually moved laterally because it didn't have any tone. Even if I knew that at that time, there was no treatment for that. Now we have treatment for that. So at that time, people suggested that you should do cricothyroid approximation with the type 1 thyroplasty. Nobody was very sure. There is no strong physiological background, but people told that to make it tighter, you can actually do. And even people told that, okay, when you are doing arytenoid rotation, the vocal cord become taut. It is not. It will not. Arytenoid rotation cannot make the vocal cord taut. It can only adduct or rotate the arytenoid so that the vocal process meets. That is already meeting. So the arytenoid rotation I did in this patient was actually waste. It was not required. Only a thyroplasty was probably required. Patient's voice improved, but it was not very great. We will see, come to the management little later, but completion, we will complete the findings. Now, always look at the ventricle, usually deeper on the side of involvement. That again, especially in a vocal cord paralysis, will give clues to you. Watch, massive ventricle here. So when you see a big ventricle on one side, you should understand that, especially in a paralysis or paralytic side, you see that is actually suggests that is atrophy. One word of caution, how you hold your scope, whether it is rigid or flexible, is very important. If you keep it in an angle, if you are bringing the scope from the left, you will think that the right ventricle is very big, and vice versa. So always look in the middle so that you will have a symmetrical overview. Otherwise, you can get false positive tests. Now look for supraglottic phenomena, especially ventricular band adduction. Some of the books say that in vocal cord paralysis or paralysis, the ventricular band contraction always happen on the normal side. I differ because I've seen at least another 10% of patients it happen on the paralyzed side or two, because ventricular band has nothing to do with the innervation of the vocal cord. It is something different. So you can here see a left vocal cord palsy. You can see the right vocal cord is overriding, but you can also see ventricular band is medializing. And what else? You can see that the left vocal cord has got little bit tone left, tone less, while vocal process meeting is fairly good enough. So we'll watch once again. Vocal processes are meeting, so that lateral cricoarytenoid is reasonably in good shape, but thyroarytenoid is little bit weak. It is flabby, but not too much flabby. Patient is trying to compensate with an overriding arytenoid on the right side and also with the ventricular end. So these many findings, and you can see arytenoid asymmetry is there. These many findings are there in a vocal cord palsy. Now look at another case. This is again a left vocal cord palsy, but here see, it is actually the left ventricular band which was hypertrophied. And over a longer case, here again, the overriding is probably, not probably, is on the right side. And as we have seen earlier, there is some amount of loss of tone on the left arytenoid and it is prolapsing little bit into the lumen. That may be the reason why the ventricular band also is medializing on that side. But you can see very well see the overriding arytenoid on the right side. Now, superior laryngeal nerve paralysis and paresis. It is very subtle, very difficult to diagnose. Many signs have been described. None of them are certain. I myself, I think, have taught many of you say that look at the transverseness of the aryepiglottic fold on the side. This was in the textbook. But I'm sure that, and I think people don't believe that now, because overriding arytenoid can actually produce a transverse aryepiglottic fold. And we have seen that 30% of the people have got overriding arytenoid, benign overriding. So just because looking at the right or a transverse aryepiglottic fold won't say that this is a superior laryngeal nerve paralysis. So this is a tricky equation. Lax vocal cord, all right. So even now, probably the most important diagnostic criteria is laryngeal EMG. But there are some clues. Some patient may be easy to pick up. This is a classical case of left superior laryngeal palsy. And again, watch the lax vocal cord and watch the abduction. There really is a very important finding. You can see that the left is very flaccid and flabby. But vocal processes are meeting and the thyroarytenoid is meeting. So it's not a recurrent laryngeal nerve palsy. Now watch here one particular point. What is just happening? Now watch here. This is a very important finding. You can see here the normal ratio between the cartilaginous cord and the membranous cord is not 2:1, but 2/5 to 3/5. So if divide the vocal cord into 5 parts, 2/5 is cartilaginous cord, 3/5 is membranous cord. But in a superior laryngeal nerve paralysis, you can see that this is actually equal, 1:1. See that? You can see the entire vocal cord here, and the posterior cartilaginous cord is half and membranous cord is half, because the membranous cord has lost its tension. So this you can see the striking difference. The right side, it is 2/5 the posterior cartilaginous cord and 3/5 the membranous cord. Here it is 1:1. So in abduction, that is why I told that don't just look at the abduction always. Pay a lot of attention to abduction and the arytenoids. They are going to tell you a lot of things. Now we come to BVCP, bilateral vocal cord palsy. Again, should be told actually bilateral impaired vocal fold movement. So it is BIVFM is the correct terminology, because we don't know whether it is a paralysis itself or a paresis or like that. Again, take a detailed history. Patient usually will have progressive dyspnea, some dysphonia also. There will be obvious causes like thyroid surgery and neck surgery. In India, unfortunately, even now, the number one cause in BVCP is thyroid surgery, which shouldn't be the case really, because now the incidence of recurrent laryngeal nerve palsy in thyroidectomy is not acceptable. That is what people are telling. Like Gregory Randolph's book say that, he said that it should be 0%. We still get paralysis, but anyway, it is still high in India. It should come down, and of course, many of them can be idiopathic. Now, how to diagnose? Inspiratory stridor. It may be at rest. It may be during exertion. It may be sleep. If at rest, it is a serious issue. If only at exertion and sleep, you have got time to act. If at rest, it is an immediate thing. And one danger sign will be flaring of ALA-NSA. If patient is taking breath each time his ALA-NSA flare, that suggests that patient is running short of oxygen, and the workload of breathing is too much. He or she will collapse or become tired later, and then go for trouble. And look for subcostal indroid. So they all will be there. That's a classical inspiratory stridor. So look for all, and look for the ALA-NSA flaring, look for the subcostal thing. All these things need to be looked into. Flexible laryngoscopy, look again for abduction, but more importantly, look for paradoxical movement. And this is very important. The fourth sentence is the most critical thing. You might many times see some movement of both vocal cords, and you might actually, this is what happens. Many times surgeon refer to me saying that, I did a thyroidectomy. Post-operatively, anesthetist looked at the larynx and told that vocal cords were moving. One was moving normally, other was flickering. Never pay attention to the movement. It is not important really. What is important is that glottic space at the height of inspiration, because recurrent laryngeal nerve invariably recurs. It is not called recurrent laryngeal nerve because of that, but anyway, the chance of the recovery is very high, but almost always synkinesis happen. So assessing a glottis at rest is not really correct, and assessing glottis by noting movement, even if that is of abduction, is not important. When it happens is the most important thing. So ask the patient to take a deep breath by sniffing it, and then look what is happening to the vocal cord. At that time, a vocal cord which you might have thought that was abducting, maybe at that time doing paradoxical movement, then that vocal cord is creating more problem. The glottic space is very, very small. So don't look for static finding, look for the dynamic finding. So at the height of inspiration, what are the both vocal cords doing? Are they in the neutral position? Are they in the abducted position? or are they collapsing and getting sucked in by the negative effect? That is different. So you might think that the vocal cords are moving, but patient may have severe symptoms. So key is that assess the glottic space at the height of inspiration. And each may be different. Here again, you can see that you can't see the posterior glottis at all. The membrane cartilaginous cord you can't see. So the abduction is very poor. So you can see there is some movement on the on the left vocal cord at the height that is just adequate. Unfortunately, the sound is here, but you probably can't hear it. Is very weak. But you have to listen to the sound and then time the phase it. And it should be at the inspiration. What is the finding here? Both were moving little bit to the neutral, so the patient was okay. But this is very, very important. Now, differential diagnosis has been put many times. Rule out bilateral cricoarynoid joint ankylosis and posterior glottic stenosis. You can do either by the EMG, but then there is a problem with the EMG. EMG, if you hit the muscle, it is all right. If you don't hit the muscle, then it may not be correct. So you may have to do the ultrasound guided, or second is UA, examination under anesthesia. So you can palpate the cricoarynoid joint like that, put a blunt instrument behind the arytenoid, push it medially and anteriorly, it should easily move. So this suggests that the cricoarynoid joint is intact. Now, interarytenoid or the posterior glottic stenosis, so it is too tight. This is a posterior glottis, this is not a bilateral cord palsy. And if you do Kashima on this patient, that will be a miserable failure. You can see that you have to put some instrument in between and just separate, try to separate and push one laterally. Normally, you should be easily able to put one vocal cord laterally. Here it is unable because there is a lot of posterior glottic stenosis. Now, we have seen unilateral vocal cord palsy, you have seen SLN, and you have seen bilateral. So we'll now quickly run through the management. Of course, I'm not going to the detail, that's not possible in this lecture, but we will tell the outline, how each case should be managed. Now, unilateral vocal cord paralysis. Pharmacotherapy, you can. I think pyridoxine, cyanocobalamin, and the nerve regenerating factors can be definitely given. Role of steroid is controversial. There is no proven thing, but again, postoperatively, some edema, there is no harm in giving at all unless there is a very specific contraindication. So I will give. If post-thyroidectomy, if there is a paralysis, I will actually give. The surgeon say that the nerve was intact, it is solely. Or there is a doubt of cautery injury, I will definitely give. I'm not very sure whether it will work. No harm. Now, I'm taking just 3 slides on the vocal voice therapy. I think this is very important, the concept. Because there are clear cases where voice therapy can be tried. And there are equally clear cases where voice therapy shouldn't be attempted. If patient, with a big phonatory gap, if the voice therapists keep on pressing the patient, they will develop compensation, and that too bad compensation, like ventricular band adduction, arytenoid coming anteriorly. They can be very difficult to correct even after a thyroplasty or a arytenorotation. So what should be done is very important. So if there is a small phonatory gap, something around 3 millimeter, you can actually do voice therapy. There are very simple thing. One is half swallow boom. Half swallow boom means you have to elevate the larynx. You know that the laryngeal biomechanics is such that when the larynx goes up in the neck, vocal cord come close to each other. So if you can keep the larynx high up for maybe by 1 millimeter, then the voice will become better. And a small gap might get even close. Brain will know it. How to do that? Many techniques. This is my technique. I will actually give water in a little bit of water inside, ask the patient to keep water inside the mouth, 5 ml, and do the gargling sound as well as the phonation. So he has to produce the gargling as well as the vocal cord sound. If just gargling sound, it is useless. So something like this. You can see that when he is doing that, the larynx goes up in the neck. Sustained. So in this way, you can actually learn. And the second is head turn. We know that this is in swallowing. We know that if you take, this is one of my fellow, if you turn your head to one particular side, that piriform fossa get obliterated. This generally we use for swallowing disorders. But see the difference. What happens when you turn the head to the left? Your left arytenoid overrides. You can see that here is overriding. So when you want to override a normal vocal cord, some patient will automatically do. If they are not doing, you can actually make the patient turn the head to the normal side. Many times this will work. So if you ask the patient, if the right side is paralyzed, ask the patient turn the head to the left. So you can see what happens. That side over arytenoid overriding, and some amount of overriding will actually attack the arytenoid closer to each other, and voice may become better. And the third is falsetto mode of voice production. Again, same as half swallow bow. In falsetto, the larynx goes high up. So the vocal cord come close to each other and the breathiness goes down. This is a patient who himself did it. No, I didn't teach him. This was a patient who underwent a cardiac surgery and developed a vocal cord palsy. And he himself corrected with a puberphonia type of voice.
3, 4, 5, 6, 7, 8, 9, 10.
So this is called paralytic falsetto. This is a compensatory strategy sometimes people adopt even without you telling, but you can tell. A patient who has got a very breathy voice, with a unilateral vocal cord palsy, if you ask them to produce high-pitched feminine voice, the voice will be clearer. Obviously, this is more useful in a female than in a male, but sometimes males also do that. And when I did the thyroplasty on him, that paralytic falsetto disappeared. So this is after thyroplasty.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Now, what else there is the role of voice therapy? Improving the breath support and resonance. That's the good thing about voice. Voice has got three parts. The actuator, that is the breath, the vibrator, that is the vocal cord, and the resonator, that is the cavity. So it is a three thing. If one is damaged beyond repair, we can still improve the voice by improving the other two. If the breath is bad, improve the vibration and the resonance. If the vibration is gone, improve the breath and the resonance. If the resonance is gone, improve the breath and the vibration. So this is always possible. So you can improve the breath support. We can teach some good resonance, like keeping the mouth open, keeping the tongue in front, use good nasality, open throat resonance, lot of things, and teach vocal hygiene. So this is precisely the role of voice pathology. This is what I'm telling. Many times, wrong advice is given, like that in a patient where no chance of bringing the vocal cord together is possible because the gap is too big. So that is the role of voice therapist in this particular condition. Avoid troublesome compensation, especially with a large phonetic gap. If you are teaching them like push-pull or something, instead of patient developing a good voice, he'll develop a very bad, rough, gravelly voice, which can be very, very difficult to correct, which can be very refractory to therapy even after a successful, proper voice thyroplasty. So this is also the role of voice pathologist. You don't need to correct everybody with your voice therapy. If the gap is too big, your role is teaching the correct vocal hygiene and avoiding abnormal compensation. Now, what is the current concept of management of UVCP? Gone are the days when we actually used to say that, okay, you will come back in 6 months' time, this will recover 6 weeks to 6 months' time. I still tell that. But most patients cannot afford to do that. For 6 months, having a voice bad is very bad. So right now, I will give the option that we do injection laryngoplasty office procedure. No anesthesia, nothing. It's an endoscopic guided. You can do transcutaneously. You can inject hyaluronic acid, which is available in the trade of Juve. Plastic surgeons know it, 1 cc. You can inject cricothyroid, suprathyroid, or what is preferable, especially in the COVID time, is a transthyroid. Nowadays, I do only transthyroid through the thyroid cartilage. Again, the conventional teaching was that you do transthyroid only in young patients because that's only where you get a cartilaginous thyroid. Otherwise, it is ossified. You can't do in an older patient. I also believe that. Now, 3 years back, I went to the German city of Jena to meet Professor Andreas Müller to learn the laryngeal pacemaker surgery. There I found he will do EMG for everybody and he will go trans thyroid. Even for posterior cricoid, he will penetrate the larynx. So I asked, is it possible? Older people, you just watch. So what he will do is that he will just infiltrate little bit of local anesthesia in the skin and also on the external perichondrium. And using a relatively bigger bore needle, like our lumbar puncture needle will be the best. You can use 20 or 21 size lumbar puncture needle. Just go through the cartilage. It will go. I have never failed after starting that. Nowadays, I don't cricothyroid. I don't do thyroid. Thyroid is terrible. I don't like it at all because it bleeds from the epiglottis and your vision is gone. Patient will cough. Cricothyroid is still do for Botox, but under EMG. But for injection, I do leg. So you can see that the assistant will be doing the scoping. You can see that left vocal cord is paralyzed. So this is an outpatient procedure. I'm just watching the larynx here. So in the neck, you mark the window just like in thyroplasty. And somewhere in the middle or maybe slightly towards the anterior part, put the needle and watch and look for the tending. Now you can start seeing the tending of the needle. Don't penetrate, but tend. Even if penetrate, no big deal. You can just push back. You can see that then my needle is tending the vocal cord. Once I am sure that I am in the para, just withdraw. Don't injecting into the rangy space. No big deal. It will be still okay, but you inject into the paraglottic space. You need to inject only one side. It will look like a blub in the beginning, but then it will beautifully become uniform and the vocal cord will become straight. So this is an outpatient procedure. The patient can go home immediately and the results are immediate on the spot. It will last for only 6 months. So, but by the time you know that whether this is going to be a recovering case or a non-recovering case, that's not an issue at all. Then we can actually decide upon the main surgery. This was a patient cardiothoracic surgery. Very weak voice. He couldn't cough and bring out the expectoration. So the cardiac surgeon was worried. Maybe that will recover, but what about the current expectoration? So we went for the injection laryngoplasty. You can see that. Just 5 minutes later, patient's voice is very good. Now, UVCP, no recovery in 6 months. That means permanent procedures. Now it is easy. We have classified 3 types of paralysis. Gap in the anterior part, gap at the vocal process, gap in the posterior. So anterior phonatory gap is a classical case. If it is just an anterior phonatory gap, you do the medialization thyroplasty, the classical type 1 thyroplasty. I'm not going to the detail because every one of you know it. Phonatory gap at the vocal process level, something like this. It is phonate gap at the vocal process as well as anterior mundane. So here, a thyroplasty alone is not going to cure the condition. So you have to do the aryteno-rotation. Aryteno-rotation plus thyroplasty. Now, phonatory gap at the cartilaginous cord, very, very difficult condition. I have not much experience. I have done till now only 2 adduction arytenoidopexy. So what you do is, I will orient you. This is the cricoarytenoid joint. You open up, see the glistening cricoarytenoid joint. This is the superior surface of the cricoid. This is the arytenoid. Take a suture, the 40 prolin from the posterior part of the cricoid, come out through the articular facet, go through the articular facet of the arytenoid, come back through the arytenoid, go through the cricoid again and fix it medially so that arytenoid is pulled medially. This was a traumatic case. The vocal cord was the left vocal cord, even though it was moving, it was far too back. So we did a reduction arytenoidopexy. It is still little bit lateral, but the voice is much better and it has become closer. Now, permanent procedure. This was the troublesome group we didn't know how to manage earlier. Flaccid paralysis, children, professional voice users. Children, you can't do obviously thyroplasty because you were not, at that time it was, now we do under general anesthesia too. At that time, local anesthesia was not possible. It was not possible in child. And professional voice users, singers, you cannot. So currently the biggest advance in neurolaryngology is the non-selective reinnervation. You take ansa cervicalis and connect to the recurrent laryngeal nerve distal end. You can see that here. There is already a thyroplasty done here, but we are also doing a reinnervation because we need to have good tone to this. I'm taking a little bit of fat. This is the recurrent laryngeal nerve ansa anastomosis and putting fat around it as a sort of stem cells. So you can do the ansa cervicalis recurrent laryngeal nerve anastomosis here. You can see that. So that is the anastomosis here done by, and it generally gives very good results all over the world. The success rate is as high as 94%. We have done more than 15. Most of them got excellent results. It doesn't make the vocal cord move, but it gives excellent adductor tone. So if during thyroid surgery, if the recurrent laryngeal nerve is cut on one side, you should in anastomosis recurrent to recurrent, but take ansa from the same side and connect it to the distal segment. So this is a patient who had a paralysis, and see that the tone was very bad. The posterior cricoarytenoid was not working. That is why the arytenoid is collapsing. We did a thyroplasty. The result was not very good. So we did reinnervation too. Voice is extremely feeble. Now 5 months later, can see that now it is that arytenoid prolapse is gone. Patient has got near normal voice, complete closure. And this is especially important for a singer. This lady had a paralysis, very bad voice, breathy voice, unable to sing. She was very sad. So we did a medialization with fat injection and recurrent laryngeal, because the vocal cord was already moving. So I didn't cut the recurrent laryngeal nerve. I took ansa and connected to the thyroarytenoid through the window. This was the preoperative finding. You can see that the left vocal cord is paretic, bowed. So we did fat injection plus non-selective reinnervation. This is 6 weeks later. You can see the fat, but still the gap is very much there. The result will take nearly 3 months, 3 to 4 months, because the nerve grows at a rate of 1 millimeter per day. So this is 4 months later. See that now the tone has become much better. And 6 months later, she was back to profession. Obviously, she is very grateful to our team, but this improvement was even beyond my expectation. So I have seen that non-selective reinnervation gives excellent voice result. And in the years to come, we might actually see many of the other surgeries just going into the background. Thyroplasty and adductor rotation even may not be required, because when you do the non-selective reinnervation, you are giving adductor tone all the adductor muscle. Right now, we don't have enough material. That is why we are still doing thyroplasty and adductor rotation. I'm not telling that thyroplasty and adductor rotation will totally go away. It will be there. There will be selected cases. But I think non-selective reinnervation come more and more. Now, superior laryngeal nerve paralysis, very complex thing. voice therapy is usually successful because the suprahyoid musculatures are intact. So even though cricothyroid is gone, you can generally cover with the suprahyoid musculature. They are very powerful pitch increasers. You can, if needed, you can do type 4 thyroplasty. I have never done for a superior laryngeal nerve palsy. Reinnervation has not been successful till now in superior laryngeal. Bilateral, immediate management. How you immediately, suppose patient has got a thyroidectomy, post-thyroidectomy and vocal cord BVCP. So the management should be trying to avoid tracheostomy. So keep the patient in proper position, give oxygen. I know oxygen is very short supply now, but I'm just telling that give oxygen, steroids, APSI, and anxiolytics. The patient will be very anxious, and anxiety will make the Bernoulli effect worse. So make them quiet. Immediate management, secure the airway. We can use CPAP because it will open up the airway. Exhalation is normal. We can use intubation or laryngeal mask. We can do cricothyrotomy emergency or a tracheostomy. So this only a minority of percentage require. Most of the post-thyroidectomy patients don't require it. They will be okay. They can manage for some time, especially if the surgeon is very sure that the nerves are anatomically intact. Now, immediate management, patient doesn't want a tracheostomy. What do? You can do a suture codepexy. This is a suture codepexy I did 8 years back. This is very unusual. Usually they cut through, but this patient was okay for so many years. So you can see the codepexy. In most of the people you can do. I will do codepexy in anybody above the age of 3. But older children and adults, you don't need to do a tracheostomy. But younger children, we have to do a tracheostomy because you don't get enough working space to do a tracheostomy. Otherwise, I will not do a tracheostomy. I will straight away go for suture codepexy without tracheostomy. So standard accepted thing right now is established cases, glottic widening, static procedures. You are increasing the breathing capacity at the expense of the voice. So the standard surgery will be the Kashima's posterior cordotomy, very predictable surgery. I've got a lot of experience with surgery. I will say that it's a very, very predictable surgery. The problem is that the voice is not that predictable. We will come to that little later because I think it again depends upon the neurophysiology of each vocal cord and each paralysis. But this is what happens when you do the Kashima, and you can see that the paralyzed cord or the cut cord move a little bit laterally and you get reasonable good space. In children, I will not do Kashima because that is an irreversible procedure, and also because in children, there have been cases which has recovered even after 4 years. So I will do only endoscopic retinoidectomy and some kind of suture codepexy. You can also do the glottic widening static procedures externally. One is the Woodman's operation, now almost forgotten. I still occasionally do, especially if you can't do the endoscope. You can't put the endoscope with a micrognathia or trismus, something like that. Then I will do this surgery. That is just like a retinal rotation, but reverse direction. You take the suture through the vocal process and fix it to the thyroid so that you're widening. Or you can do in a young child, you can do posterior cricoid split. This is a 2-year-old child, and you can see after posterior cricoid split, this much space is there. You get reasonably good space so that the child can be without tracheostomy. This can be done endoscopically too. I think Kishore Sandhu does endoscopic posterior cricoid split. I don't do that. I do open only. Now, there are 2-3 things that are coming up. Some of them are really exciting, but we are in the early days. So they are dynamic procedures. That means you are expanding the airway, not at the expense of the voice. Voice also is good. So there are 2 things. One is the selective reinnervation, and the second is the laryngeal pacemaker. Laryngeal pacemaker has been there for quite long time, maybe 20 years, but somehow it got stuck in FDA with FDA. Now with the Professor Andreas Muller leading the thing, it is almost near the breakthrough. I think they have already done more than 8 patients. They got very, very good research. So they connect to the posterior cricoid node. It was supposed to be in the market this year, but the COVID has caused sort of problem. So maybe another 1 or 2 year. The company Medal, which is actually marketing the cochlear implant, is marketing the laryngeal pacemaker too. I have gone for some training with Professor Andreas Muller. Surgery is not a very difficult issue. It's like putting the electrode into the posterior cricoid. Now, selective reinnervation of the larynx is a very challenging surgery. If you have seen non-selective, you have excellent result, 94%. And out of my 16 cases, I think except one, every patient has got very good voice. One patient has got still some gap. Maybe I will do a thyroplasty later. Till now, I have done 6 reinnervations, bilateral selective reinnervation. The first 3 we could decannulate, but I am not comfortable. I am not happy with the result. But I think my teacher, Professor Sean Paul Murray, told that it's okay. You take some time. There is some movement. I could actually decannulate, but the 4th patient actually failed. I couldn't decannulate. This is a Nigerian patient. Maybe I committed a blunder. On one side, I saw the nerve was intact, so I didn't go about doing that. Even though it was intact nerve, it was actually a synkinetic nerve. So I erred on the side. I should have done the bilateral selective reinnervation that side too. I did only one side. So that patient I couldn't decannulate. The other 3 patients I could decannulate, but they are not. I will not say they normal. The last 2 patients, one was done on February 12th and the second was on February 19th. That is a child, 3 or 4-year-old child from Raipur. I have got great hopes about. Maybe it will become better. I don't know. So right now my experience is limited. So essentially the treatment concept is that you take the phrenic, which is a very powerful abductor nerve, to the posterior cricoid node. So this is a phrenic nerve. It has got C3, 4, 5. You take only one root on one side and do a Y connection to both muscles so that the diaphragm is not paralyzed. And for the adductors, you take ansa hypoglossal, which is a very slender nerve. This is the hypoglossal nerve and this is ansa hypoglossal. You need only weak adduction because already adduction is there. So this is one of my patient, preoperatively something like this. Stridor and bad voice. So this is after 18 months after surgery. Voice is much better. Some abduction is there, but never. I have seen Professor Mary's results are stunning. They are almost like normal. I never have that kind of result, but I'm a novice in that field. Hopefully, we will learn more. And maybe they all will go out if this thing comes in the future, maybe neurotropic agents. Right now, we know that recurrent laryngeal regenerate, but the problem is that the regeneration is haphazard. Adductor go to abductor go to adductor, ends are all hopeless. Now, there are neurotropic agents. So there is a suggestion that this has been done in rats. If you inject specific neurotropic agent for adductor fiber like a netrin, then all the adductor fiber will be attracted to that muscle. So there is no synkinesis. Similarly, glial cell dependent neurotropic factor attracts abductives. So you can actually inject into the posterior cricoid node and you can hope that the abductor will go back. If this happens, this is terrific. Then there is no reinnervation, no laryngeal pacing, no Kashima, nothing. So all things are exciting. Hopefully all this will come before I think. I want, this is my puppy. He's watching Chief Minister talking about the COVID situation. Anyway, why I put this thing is that you have to really closely observe the larynx. Even though in the beginning, we don't understand it well. You may not understand at all. I didn't understand anything in the beginning because even though I was a laryngologist, I never looked at the arytenoid. I never. Then after reading certain papers and after seeing myself, I saw that there are a lot of things to be learned, which I didn't. If you don't know this, you are not going to look at it. So keep on develop the habit of close observation, even however unfamiliar it may look like to you. Thank you.
Thank you, sir, for that very enlightening webinar, sir. I think all of us got, I think all the points are very new.
Thank you, Poornima.
Yes, sir. Now I request our participants, if you have any doubts, you can you can feel free to ask, sir.
Dr. Jayakumar,
Yes.
this Dr. John Panikkar.
Uh-huh.
Thank you very much for a wonderful talk. I just want to know the difference between selective anastomos and non-selective.
Yes.
What exactly you mean by that?
Non-selective means you take an adductor nerve and work during phonation or exhalation only.
Okay.
And connect. So you are not bothered about the abductor. You are taking the adductor nerve and connecting to the recurrent laryngeal nerve.
Okay.
So it will go to adductor, but adductor constitutes 75% of the nerve bulk. So patient will have very good adductor tone. Vocal cords are not going to move.
Okay.
But in unilateral vocal cord palsy, you don't require vocal cord to move. You need only good medialization.
Yes. Good medialization.
But in selective, bilateral, you require selective. You need the abductor to go to abductor and adductor to go to other. Otherwise, it is useless.
Yeah, correct.
So that is the difference.
Yes. Thank you.
Jayakumar sir, I am Reggie here.
Reggie.
Sir, one thing, there are a lot of postgraduates attending.
Yeah.
Can you please tell them regarding the various positions of the vocal cord, laryngoscope, paramedian, how much millimeter from the glottic, all those things, the cadaveric position, full abduction.
Yeah, right. So there was previously this median, paramedian, cadaveric. There was some confusing terminology. So right now we go by the three other position. That's the adducted position, the neutral position, and the abducted position. Okay? So the adducted position means the vocal cords are meeting. Abducted position means it is little more lateral and neutral. Abducted means far too lateral. There is no software as of now to measure on the vocal cord. What we do is that we will take the length of the membranous vocal cord, okay, and divide it into, say, third, and measure the distance of arytenoid from the midline and compare with the length. So you can tell that the arytenoid on the paralyzed on the right side is 1/3 the length of the vocal cord lateral, or 2/3 the length lateral. Did you get the point, Reggie?
Yes, sir.
So you will call, if it is totally adducted, you will call it adducted position. If 1/3 the length of the vocal cord is lateral, then it you call neutral, and if it is 2/3, you call it abducted.
Okay, now the whole terminology is gone. The cadaveric position.
That is confused. The paramedian, median, cadaveric is gone.
Okay, sir.
Because truly speaking, there is no cadaveric. Because in recurrent laryngeal nerve, it is near impossible to totally paralyze. They invariably regenerate. So synkinesis happens. So there will be some tone, and it varies from person to person. And again, it is very, very important you assess the position of the vocal cord and the height of inspiration. In a bilateral cord palsy, that is the most important thing.
Okay, sir. Thank you for the excellent presentation, sir.
Thank you, Reggie.
Thank you so much, everyone, for your participation. And we will